I think that's an important point that Peter makes, that the hospitals in Vermont have a very strong medical ethic. They take care of people whether they can pay or not. That isn't the case in other places.
Right.
There are many places in New York where basically if you don't have health insurance, they shove you out the door. In Vermont, they take care of everyone, and we have to remember that in terms of hospitals, most of their costs are fixed, which means they're there whether there are patients in the bed or not. And in order to pay those fixed costs, paying the nurses, paying the dietitians, people to scrub the floors, the rent, the lights and all that, they need adequate payment. And as Peter alluded to, they're not guaranteed that adequate payment. And they're certainly underfunded by the state payer, which is Medicaid. And that is probably what their biggest fear is. The real question, though, is there enough money in the system to pay their fixed costs? And the answer to that, again, is yes. But we need a rational system, and you have to get the money from somewhere. And basically, that's going to come in the form of the unnecessary paperwork that we're now paying for. There's more than enough money to adequately fund the fixed costs of hospitals.
And the hospitals have the burden of having to bill in this crazy system that we have. So, you know, they're not sitting back in the hospitals going, wow, the system we have is beautiful, and we're really happy. They're very unhappy. They're very worried. They're very concerned that they can survive. And this change is about ensuring that they stay healthy, too, because they do great work. They make Vermonters healthy. They don't want to be pushing paper any more than the rest of us.
If they didn't have to send out bills, that's a whole department in the hospital they could eliminate.
And you were mentioning Canada before. In Canada, what they do is they fund their hospitals in a lump sum payment, so that you can't even find the billing office in a Canadian hospital. It may be two people in a personal computer in some little tiny office to bill Americans who happen to wander across the border. There is no such thing. They get their fixed amount, they get a lump sum payment in every single month or every 2 weeks, and that's how they pay their staff. And that is decided on ahead of time. So that has the assurance, at least, that hospital executives, that they can pay their staff. But then also it's a way of containing costs, because essentially healthcare becomes more like a public good, where we accept the fact that we all want those services there. I mean, everybody wants to make sure we have an adequate ER and an ICU and the pediatrics and all those things. We want to have them available. We just have to find a way to pay for them adequately.
When I lived in Quebec, I used to have a plastic card, like a Master card.
Right.
And anytime I went to a doctor or a hospital, I just showed the card and they swiped it, and that was the end of it. And everything beyond that was free.
You had to just worry about getting better.
Never got a pill. Never got a bill.
Yeah, yeah. Yeah.
It's not free. It's just not paid for in the rather ridiculous way that we do it here.
I thought it was free.
Yeah, it was free. It was free at point of service. But it isn't free to society. I mean, the point is that we're paying for it. But Canada gets a whole lot more for their money than we do. And imagine how much better off we would be if we could pay, even if you paid, 25% more than Canada, and we could get a whole lot more, because Canada does have some shortages in some areas. But with the amount that we're paying, we actually could afford to buy many, many more services than the Canadians actually enjoy.
A lot of people have talked about the Massachusetts system. Is that one of the systems that Dr. Shao is studying?
Thankfully,
I hope not.
Yes, it hasn't been doing very
Here's the problem. This is what politicians do. They don't have the courage to take on the insurance companies. They got a lot of money, special interests. They don't have the courage to take on the pharmaceutical industry. I can tell you that as long as you're nibbling around the edges on health care, which is what the Massachusetts model also does, you're going to lose. Change is not going to happen. You're going to continue to see double-digit increases in your health care costs. You need to redesign the entire system. And I sometimes ask us to work backwards as we think about this. Let's just pretend for a minute that we were founding a state with 660,000 people in it. And we decided that it was a right and not a privilege to keep them healthy. It's not a very radical thought. A modern society keeps their citizens healthy. And we decided that no one was going to be turned away from the hospital, which happens to be true in Vermont, that everyone was going to have access to quality, affordable health care, which we have in various forms in Vermont. If you came in with a blueprint of the existing system in Vermont, multiple payers, spending 10 to 14 cents of your dollar just collecting the money, and I can give you lots of lists of other extraordinarily inefficient things we do, duplicating services because the last provider might not know what the provider the provider before did to you. I mean, the list goes on and on. You would literally say to us, listen, folks, you're fired. This is nuts. That's a non-system you just put on the table. Go back to school and learn how to design a system. Hire the next guy. That's what we need to do.
And Dr. Richter, the cost of medical education in America is higher than most other countries, many of which provide free medical education. Could we reduce the cost of health care by providing free higher education to our young people, as most civilized countries in the world do?
We could, and I think the other important thing that would happen is we would likely increase the distribution of primary care to specialists. Because right now what happens is the average student comes out with $200,000 in loans. And the average primary care physician isn't going to make enough for them to be able to pay that back any time soon. So what a lot of students, they take a look and they go, gee, I like this. I like dealing with, the family. I like being a family physician. It would be wonderful, but I can't afford to do that and to pay back my loans. It would have to be done at the national level. It isn't something we could really reasonably do at the state level. But we could really fully fund medical education for probably about $3.5 billion. And when you consider how much we've spent in Iraq, that probably, I think, I don't know, we're probably talking about a week or so. It's certainly something we could do in this country without much of a problem. And then we would probably see more people going into primary care, because it is a very attractive profession and specialty. It's just that it is very, very difficult to do when you are being paid far less than you would if you were a cardiologist or an ophthalmologist.
Terry, that's a problem worth talking about. It's always on the burden of those who are proposing change to prove that it will work. I ask this question. If we stick with the current system, let's just go to what Deb's just talking about. Our primary care providers who are making a pittance to do the work they do to keep us healthy. What's going to happen if we stick with the current system? We are not going to have primary care providers in rural Vermont. We're a rural state. That means we're not going to have the docs there getting paid enough to continue to make us healthy, and the nurses and the other folks that are providing the services to keep us healthy. So we're really sort of up against a rock here. If we don't make change, the system will crumble, because we right now are having trouble recruiting primary care physicians to a state that has an aging population. We all know that aging people use more medical resources than young people. And the docs and the providers, the nurses, all the people in the system, they can't afford to work for the wages that we're paying them. So instead of sending that money to the insurance companies, who, by the way, are doing just fine, to the pharmaceutical industry, who, by the way, are doing just fine, we've got to design a system where our providers can afford to keep us healthy. If I said to you, hey, we have a system right now, we can't find providers, it's going to be worse in 5 years, and I said, I'm just going to keep nibbling around the edges of what Brian Doobie is saying, I would say to that person, listen, that's not a plan. That's not acceptable. Tell us what you're going to do to ensure that in a rural state, our providers get paid enough so that they can feed their families and pay their mortgage at the end of the day.
I think the other thing that people bring up is that why can't we use nurse practitioners? And actually we can. We should employ more nurse practitioners in primary care. They do a fine job, and studies show they actually do just as well as primary care physicians. But the thing is, there are a lot of nurse practitioners and physician's assistants who don't want to go into primary care either. And one of the other factors, besides it being underpaid, is the amount of paperwork that we have to deal with. If I'm gone for 1 or 2 days, I get 5 stacks of charts this high on my desk that I have to deal with, and a lot of that is unnecessary paperwork. That needs to be eliminated. I think, again, if we talk about a single-payer system, would be vastly reduced, because I'd only have to deal with one set of rules for every single patient instead of dozens and dozens and dozens of different rules, regulations, and paperwork.